Nasogastric tube. A general practitioner may be required to insert a nasogastric tube, more commonly termed a Ryle'S tube, to give stomach wash in a case of poisoning as immediate first aid or for feeding unconscious or semi-conscious patients at home. Techniques: take a Ryle'S tube number 16 and lubricate its tip with liquid paraffin or xylocaine 6 gels. Patient comfort can be increased by giving xylocaine liquid to swallow 5 minutes before the procedure. Inspect the nostrils and select the nostril which is roomier. Fix the head with the left hand over the forehead. Turn the tip of the nose slightly upwards and very gently introduce the tube into the nostril vertically. That is, along the floor of the nose. It should be pointing below the level of the ears. You will first feel a small resistance of the tube touching the posterior pharyngeal wall and turning downwards. Introduce it for another 1 centimeter until the tip lies at the upper end of the esophagus. Now stop here for a moment and let the patient relax. Ask him to breathe through the open mouth. Then ask the patient to swallow saliva, and exactly when the larynx moves up, push the tube forwards into the esophagus. If the patient coughs, usually violently, withdraw tube 12 immediately. It had entered the trachea. Let the bout of cough subside. Then try again. If the patient gags excessively, tell him to open the mouth and inspect the throat. If the tube has curled into the pharynx and mouth, withdraw it and try again. Once the tube has entered the esophagus, push it steadily ahead. No need to ask the patient to make swallowing movements now till the first black mark on the tube is crossed and stomach contents start flowing out. Generally, the tube is advanced up to the second mark. After confirming that the tip of the tube lies in the stomach, fix the tube with a ½ centimeter wide adhesive tape, starting on the nostril, going round the tube 2 times and ending on the other nostril or cheek. Confirmation of tube position in the stomach. It is very important to be 100% sure that the tube is in the stomach, particularly when you are going to feed the patient through it, and more particularly when the patient is not fully conscious when the tube may enter the trachea without eliciting cough reflex. Aspirate the tube with a 20 cc syringe. The aspiration of stomach contents confirms the position. Auscultate over the left side of the epigastrium. Now inject 10 ccs of air through Ryle'S tube with a syringe. Auscultation of a bubbling sound over the stomach is confirmatory. If in doubt, dip the outer tip of Ryle'S tube in a water bowl. Air blast with each expiration suggests that the tube is in the trachea. Ryle'S tube feeding. Never feed a patient through the Ryle'S tube unless the position of its tip in the stomach is confirmed. Attach a funnel or a 20/50th cc syringe barrel to the open end and pour the liquids to be given. Let the liquids run into the stomach by gravity. Thicker liquids may have to be pushed with the syringe. Feed 100 to 200 cc every 2 hours. Aspirate before each feed to confirm that previous feeds have moved into the intestines and stomach is empty. Very important in unconscious and bedridden patients who may vomit large quantities, and aspirate. After every feed, flush the Ryle'S tube with water to avoid clogging, then occlude the tube. Feeds that may be given: milk, plain or with protein supplements, all soups, electrolyte solutions, ready-made preparations like Recupex, and fruit juices. Stomach wash. In poisoning, it is vitally important to wash out the poison as fast as possible. So introduce the largest available Ryle'S tube, like number 22 or 24. Push in clean water or dilute potassium permanganate solution 200 to 300 milliliters at a time, very rapidly into the stomach, and let it flow out. Repeat this till returning fluid is clear. Don't forget to collect the first sample in a bottle and send it with the patient to the hospital, where you will refer him for further treatment.